Good afternoon, everyone. My name is HITH-led, and I'm one of the board members of the Hospital and Home Society Australasia. I would like to begin by acknowledging our country. So, as you can see, we're all from different nations, and we'd like to acknowledge by the traditional owners of the lands on which we're meeting online today, each one of us from our own homes or workplace. For me, this is the land of the Wurundjeri people of the Kulin Nation, and I pay my respect to the elders past and present. Today, we are fortunate to host this HIT Grand Rounds webinar, focusing on reducing emergency department presentation through innovative integrated models of care. We're joined by two incredible teams, the Alfred Health from Victoria and Tasmanian Health Service from obviously Tasmania. Each will share the unique programs, followed by a discussion comparing their models. This is a fantastic opportunity to delve into practical solutions and to foster collaboration between HITH services across Australasia. I encourage you all to actively participate in the discussion later and share your thoughts or questions in the chat. I would like to take a moment to thank everyone who made this event possible, which are our speakers, you, our attendees, and the social society members whose financial support ensures events like this can continue. If you're not yet a society member, now is a great time to join. Just scan the QR code in the corner of the screen to become part of this growing community. Before we begin, I would like to remind everyone that our guest views are their own and they do not represent the official position of the HITH Society Australasia. Likewise, any opinions I share today are entirely my own. Now, let's dive into the exciting session, starting with the presentation from Alfred Health. Over to you.
Thank you, Iftar, for that lovely introduction. I'll just quickly share our screen. You have able to see our screen okay? Great.
Yes, we can.
Minimize this. So thanks for the opportunity to present today. What have I done? My name's Archana Thaparan. I'm a general physician here at Alfred Health, and I hold a deputy director position with the department overseeing our community programs.
And I'm Felice Borgmans, and I work closely with Archana and a range of other managers, and I'm the manager of clinical service design in our program.
Now, sorry, Iftar, before we start, are you still seeing yourself in the corner of that screen, which is going to just obscure my slides? I might do that. That might be better. Yeah. Okay, lovely. So we're going to present today on the service that we're running here. Felice, do you want to start?
Yeah, so we started a model of care called GenMed HITH in 2023, and we soon realised that we couldn't run this model on our own. We needed to be surrounded by an ecosystem. So our presentation is around a GenMed HITH-led ecosystem of care. We started our model of care in March of 2023, and for a cohort of patients that had only really represented less than 1% in our hospital and the home program until that point in time. And this new cohort was deemed, had been traditionally deemed too complex, too fragile to actually be cared for in the community. But we thought we'd challenge ourselves, and we set this up to sort of be a separate stream in HITH as a bit of a pilot project to start with. We're now integrating it. But we've learned a lot from our patients, and we've really come to understand that these are very complex patients. But of course, the more complex a patient is, the more complex the systems are with which they interface as well. So it's not just patient complexity, it's a whole of system complexity that you're actually dealing with when you're working with an elderly population. So this population, about 70% of this population that we care for in our program are over 80 years old. They have a lot of multimorbidity, a lot of polypharmacy, and with that comes a lot of social needs and psychosocial needs and a whole range of other complexities and specialists with whom they interface with. So we very soon realised that we were not able to manage this on our own, and we needed an ecosystem of services. So this is the next one. Yeah. As a result, fortuitously, other services were had developed around us. We didn't want to create a whole new kind of platform to work from and a whole bunch of new services and fragment things even more. So we worked with what we had at the time, and that worked very, very well because we're actually working with a group of very like-minded services that sit around us. I guess one of the most critical services is the General Medicine Acute Streaming Team that we call GMAST. And that service is located in the emergency department, and it's run by a consultant, a Gen Med consultant and registrars. And they are really sort of key navigators of patient care from the ED. And they're a key point of diversion from the hospital and a key point of diversion from the quaternary sort of side of the hospital as well to the less acute sites. So we get a lot of our work from GMAST, and they're a great point of escalation for our patients as well in the community when needed. Then we've got our complex care program as well in the community. So we call that the Hospital Admission Risk Program, and they do a lot of care coordination, patient interviewing, motivational interviewing, health coaching, as well as providing medical oversight. And these are non-admitted patients, but we work very closely with this group. And in fact, our doctors are the same doctors that oversee this service. And about 30% of our patients stream between this program and the Gen Med HITH program. And of course, the wards are really critical as well. So they're a great place, of course, to stabilise, and we know what goes on in wards as well. But we try to make that kind of the least part of the patient journey. And then, of course, our clinics are very important in the model as well. So the Gen Med HITH clinics are a great place to review, refer patients into Gen Med HITH, but also a place to de-escalate care to as well. And just there's an after-hours response in regard to all these services, particularly from GMAST over the weekends as well, providing that medical cover. And our medical staff, as I said, in Gen Med HITH, work across both Gen Med HITH and the complex care program. So our workforce, you can see the EFT breakdown there on the side of the slide, but it is a very multidisciplinary workforce. We work in a very kind of egalitarian way with one another. It's pretty non-hierarchical. Everybody's voice really matters in the team. We've got fantastic general medicine consultant oversight of the model of care. We have advanced trainees working, one EFT in Gen Med, well, one EFT dedicated to Gen Med HITH, but they work across two streams, as I said, HARP and Gen Med HITH. So you've got 2 EFT in total. We've got a clinical nurse manager. We have nurse coordinators and nurse clinicians, and they swap roles as well. They're interchangeable. We've got an allied health lead and an allied health team, which is a small team but incredibly valuable, and our trusty clerical staff as well that are amazing in the team as well. Just to give you a bit of an insight of the importance of allied health, with the introduction of allied health into this model, which was sort of crept into the model probably about halfway through now, and really increased its EFT, it's been such a valuable model in terms of decreasing falls. So we would have many falls a month, about 10 a month, and we've sort of got that down to about 1 a month now, just through having in-reach allied health, targeting those patients. Any patient over 75 automatically gets a home visit. But we also have social work that are incredibly important for maximising our package care, particularly for patients that need nursing services and wound care and diabetes management as well. Our OT is also invaluable around that managing falls and a range of other practical things. And then we've got some fractional sort of EFT that we kind of buy into the service as needed. But you can see the breakdown of allied health usage there on the right of the slide against the age groups, and clearly the over 80s and over 70s really are using the bulk of that allied health resource.
So we've got here a slide just showing some of the DRG level data for discharges from our general medicine hospital in the home. We have tried very hard not to run a disease-specific model or have particular streams so that we can individualise the care that we deliver for our general medical patients. But I thought it was useful to share this slide with you to show how it reflects and compares to an inpatient general medicine ward, which I think it's fairly parallel the sort of conditions that we are looking after. We do look after a lot of heart failure, but also sort of outlines the complexity of the patients that we're looking after, as well as the fact that we're not limiting ourselves to intravenous therapy necessarily in terms of the delivery of care. Some of the things that we're doing, I think, in conscious in putting this presentation together, having heard from our wonderful Tassie colleagues to show you what parts of our service are a little bit different. We are very well integrated with our inpatient general medicine teams. So we actually sit basically aligned as another ward with our general medicine service, which has ward-based care at the Alfred side, as well as ward-based care at the Sandringham Hospital. And so a lot of our care is around supporting early discharge from hospital, as well as admission avoidance. So taking those patients directly who have been seen by our general medicine team in the emergency department into HITH. So as you can see in the graph above, the proportion of care that our patients are receiving is increasingly more so in the hospital, in the home model, rather than the inpatient care. So they might spend a couple of days in either a day in ED or a couple of days on the ward and then transition to our service. And we're able to, through our model, deliver 8 to 10% fairly consistently of our overall general medicine acute care in the home now through this model, where previously, as Felisa spoke to, we were less than 1% of our hospital in the home service. In terms of that direct from ED activity, that makes up about 11% of our general medicine HITH activity. And we do share a lot of patients with our HARP service. So the HARP really underpins our ability to provide flow through our general medicine HITH. So stepping down from HITH into HARP. And that allows us to have capacity to support the inpatient services by having available beds. Just some high-level data for you about the service over the last 6 months, whereas we have been running since March of last year. So we've got about 10% of our acute care at home. That equates from Jan to June to 2,116 bed days delivered. 105 patients in that time were a shared care model, and GMAST is a key part of our model there. We thought it was useful to share with you a little bit of the strategies that have helped us in engaging our inpatient services and positioning ourselves to deliver this care. So GMAS, as we've identified, as a key part of our ecosystem. We have consultant staff that rotate across GMAS, as well as our community teams and our ward services. And also our registrars have often worked in GMAST and then worked in the community. So that shared knowledge and that shared culture of home first, that shared confidence in the ability to deliver care at home, and an understanding of what are the pieces that are required to deliver care at home, what are the potential barriers, what do I need to know about this patient in terms of their home environment before making a referral, has been really key. And we have excellent dialogue back and forth with those services. So the GMAS team is able to call us and say, we have a patient we think can go home, and we're able to get one of our nurses to go down and provide the intake, and they provide a medical handover to our team, because we see ourselves as one team. So we're not trying to duplicate care wherever possible. I think that rotational staffing, especially at a consultant level, has been really a key strength for us in terms of integrating ourselves as part of the inpatient service and not seeing ourselves as separate. It has helped that culture shift and the attitude towards risk, attitude towards pragmatic care across all of that. And we have the same sort of rotational shared workforce with our nursing and our allied health and actually our pharmacy colleagues, all often working either in the ED space or the inpatient space and our HARP space as well. We've also put a lot of work into presenting in our grand rounds, in our teaching. We participate in the morbidity mortality meetings for our general medicine service. So at all places, we're trying to be present and visible to the rest of the team, which is obviously a team that turns over quite quickly. We provide some orientation at the intern and registrar orientation as well. And on a daily basis, we have presence at our journey boards, so our ward-based journey boards from a HITH or HARP clinician, often interchangeably, to remind people of the availability of that service, to offer helpful navigation and tips of how we might deliver care outside the home, so outside the hospital. We thought it was best to just include a patient story to illustrate how our services are working together. So Mr. HL is a lovely elderly Greek gentleman who came to us in May of 2023. He'd had a long-standing history with heart failure with reduced ejection fraction and multiple interactions with the Alfred through that service, through that condition, as well as through our outpatient services. Following one of his inpatient admissions, he was transferred to General Medicine Hospital in the Home for ongoing IV diuresis. We were able in that time to further conversations around what was of value to him and what was important to him, which was always quite clearly to be at home, surrounded by his family and supported by his wife. He got great quality of life out of being able to go out for a coffee with his family and be at home. And so we were able to start conversations also around what does end of life care look like, what is the palliative trajectory of heart failure as well. He stepped down from our hospital in the home to our complex care program, had further education and health independence type experience around how to manage his heart failure, how to recognize when he was having a deterioration. And there were times where he did deteriorate by nature of the trajectory of his disease, and he was able to be either admitted to hospital when he was really unwell or directly into our General Medicine Hospital in the Home for further IV diuresis. And through those multiple admissions, we were able to progress the discussions around palliative care, engage him with community palliative care, discuss what does a good end of life look like for him. And he ultimately passed away earlier this year, surrounded by his family at home, which I think was really valuable for us to be able to be part of that story, and really shows how we were able to network our services to deliver care that was of value to him and matched his care trajectory. So overall, this is the sort of ecosystem that we are running here with our General Medicine Hospital in the Home largely at the centre of it, but really actually the patient at the centre of it, to be able to network our services, deliver the care that the patients need depending on where they're at, either in terms of their values as well as in terms of their medical complexity. For us, escalation of care to the hospital or into HITH is never a failure. It's simply what the patient needs. But having shared goals and values across all of our services, and as much as possible, shared pathways, shared attitudes to risk, shared values is really, really important. So that's sort of the overview of our services, and we're very happy to take any questions.
Thank you so much, Archana and Phyllis. We'll wait with the questions until the end. So you can still put in the chat, but we will now go over to the Tassie team to see how their model works, and then we can have a discussion between. Perfect.
Great. Well, good afternoon, and just like to thank the HITH Society for giving us this opportunity to talk to you about our service. My name is Iestyn Lewis. I am an emergency physician and head of department of Hospital at Home here in Hobart in southern Tasmania, and I'm here with the Hospital at Home team to talk about our direct community admissions pathways onto our services and how that impacts strain on the ED. But to really sort of talk about that, you will need to understand how our model of care works. So our Hospital at Home has been an evolution, and I will talk a little bit about that evolution shortly. But today, our Hospital at Home is 26 beds. That's a new thing. It's been 22 for most of the year, going up to 30 soon. But those 26 beds are divided as 18 acute beds. They look similar to the Alfred's beds. They're acute medical beds in the community. And we also have 8 subacute beds, geriatric and evaluation and management beds. And we'll talk a little bit about those in a minute. We're open 7 days a week, 7:30 in the morning to 10:30 at night, with a 24-hour sort of phone line, which goes to the consultant and part of our nursing team for help. We see 160 plus patients a month, of which 70 of those are admitted onto our unit. The other half are seen as rapid response patients. We have an average bed occupancy of 90%, and 60% of our admitted patients are admitted directly from the community. The other 40% are admitted either directly from the ED or from the inpatient units at the hospital. Now, our service is divided into 3 arms, a rapid response arm, an acute arm, and a subacute arm. The rapid response arm is a little bit like our emergency department or an urgent care centre. This is the arm we use to go and see patients in the community to make an assessment about what their needs are. And that arm is activated by any healthcare professional. And once we've got the history and the intake nurse knows what that patient's needs are, we will send out either a nurse or a nurse and a prescriber to go and see the patient. So a typical nurse-only response may be a skin tear or a patient in a nursing home that needs a catheter change that has been difficult. Or the patients may be more complex. They may be concerns over an exacerbation of heart failure or soft tissue sepsis. And our team will go out, see that patient and make an assessment. If that assessment is that patient needs to go to ED, the patient will be diverted onto the emergency department. If that patient is more appropriate for another service that the Tasmanian Health Service provides, we will refer them on to them. Otherwise, we will have a look, and if we can accept the patient, we will accept the patient for the care that they need. Now, that may be they have an acute problem, exacerbation of heart failure, soft tissue sepsis, urinary sepsis, complex medication management, COVID requiring remdesivir infusions, and that patient will be admitted to our acute service. Now, our acute service is under the supervision of one of our sort of multi-specialty specialists. We have a mix of emergency physicians, GPs, general physicians, and geriatricians who are in charge of our acute unit, and we will provide that acute care. Our length of stay for those acute patients is 5 to 6 days, and a patient can move quite easily from rapid response onto acute, and then they may be discharged, or they may need our subacute service, our GEM at home service. Now, this is under the leadership of a geriatrician with a very comprehensive allied health team. And our primary aim there is to keep elderly and vulnerable people at home and out of aged care facilities and try and prevent future hospital admissions. Our average length of stay here is about 14 days. And we will send in our very diverse allied health team. We have a social worker, physios, OTs, podiatrists, dietitians. We even have a speech therapist and a psychologist. So it's a pretty comprehensive team aimed at keeping people at home. Now, that didn't just happen overnight. This has been an evolution. And the most, of this model of care, the starting point of that evolution was probably in 2019 when we set up a rapid response service, community rapid response. And that was a nursing and nurse practitioner-led team that was activated by GPs who identified patients at risk of emergency department attendance. Now, that may be for a one-off intervention, those skin tears, lacerations, blocked catheters, something that needed a one-off intervention, or something that may require a longer intervention, such as cellulitis that may have required a few days of IV antibiotics and monitoring. And the GP would ring our service, the nursing and NP team would go out, make an assessment, start the treatment in conjunction with the GP, and the GP would hold governance of that patient. Now, some GPs really embraced this service. Others were a little bit reticent, partly because we weren't remunerating them for any of their time and involvement in this. But the service was working quite well in a small way. And then in 2020, as part of the sort of COVID response, we started to look at how we could get patients out of hospital earlier, and using some of the resources that the community rapid response had, we piggybacked on a medical team to provide that substitution of care at the end of a hospital stay for patients coming out of ED or Gen Med, and we provided that care in the community. Also during 2020, we put together a rapid response allied health team, which could be activated by our ambulance service or ED. And that was designed to provide those OT, social work, physio skill sets to keep patients from, re-attending hospital. So we were running these sort of 3 parallel services, and we started to look at how this was working and decided that maybe we needed to integrate these services a little bit better. So throughout 2022, we started to do some gap analysis. And then through 2023, we started to rework our model of care to where we are today and to our expansion beyond today. And that reworking of the model of care was very much aimed at efficiency. We identified particular at-risk groups that we should be concentrating on. And the frail elderly are our biggest groups, but any vulnerable population is, in our line of sight. Now that may be people with disabilities, it may be substance misuse, a range of vulnerable groups. In that process, we decided that why was this only limited to medical referral? And we decided that we would just open up to all healthcare professionals and see what happened. We also recognized that our referral process needed to be simpler, and we needed to expand our catchment area so we could greater serve the population that we cover. And one of the big drivers behind this was the access block in our emergency departments. This is the Institute of Health and Welfare data. This is the 90th centile length of stay for admitted patients in ED. And you can see here, last year, Tasmania was leading with 10% of admitted patients spending more than 25 hours in our EDs. And we needed to work on ways that we could target those patients and reduce that number. And the ideal way was for those patients never to hit the ED. If we could admit those patients directly from the community, we might start to have an impact on that access block issue. And you can see here, this is our admitted patients and their referral source throughout 2024. So we opened our new model of care at the end of 2023, and our community providers were quite enthusiastic about embracing that. And now now around about 60% of our patients come directly from the community, bypassing the ED, bypassing the hospital in its entirety. And that, reduces some of the problems of particularly frail and elderly people being in the ED and having those very prolonged stays that result in excess delirium and deconditioning. We now have an avenue of being able to avoid that altogether. So what community referral providers are there out there? Well, this is a mix of both our admitted patients and our community rapid response patients who would otherwise end up in ED. And you can see here that GPs still remain our biggest referral source. And we really capitalized on the relationships that we had with the community rapid response team over the last 5 years to get GPs to refer to us directly. But you can see throughout the year, there has definitely been an increase in direct referrals from our ambulance service and our community nursing service, as well as our aged care facilities. And then the other group is just a big mix mash of allied health, private specialists and outpatient clinics. You know, outpatient clinics know they're going to have to send patients to ED, but they will often ring us and we will go out and see the patient in their home and carry out their admission there. And all of this occurs through our 1-800 number. All community referrals come in through this number. They don't even need to fax anything. They speak to one of our incredibly experienced intake nurses who ascertains what the patient's needs are and whether or not we can meet those needs. We have no particular, diagnostic criteria we require, just a case of whether or not we think we can do it. We will then admit the patient onto one of our services, whatever's most appropriate, and go from there. And patients can move quite freely through our services from rapid response to acute to subacute. If they get increasingly sick again, they can bounce back from subacute to acute and then back to subacute. So they can move quite freely through the services. For certain groups, we have referral pathways that we use. And this is our Ambulance Tasmania referral pathway. All the ambulance crews have an app they use, their clinical practice guidelines, and we're on there. So they can decide what our inclusion and exclusion criteria are, what our catchment area is, and this guides them through that. We have developed a tool for aged care facilities. We had noticed that a lot of aged care facilities, weren't able to access some of their GPs in a timely fashion. And so patients ended up in ED, and this pathway bypasses that. Now, what impacts that had? This is data from the first 4 months of the last 3 years. In 2022, we were only admitting from the ED and from the inpatient units. And you can see there that very, very few patients came to us directly from the community. That was mostly as sort of personal favours or patients that we knew. As we started to adapt our model of care, we opened up to GPs who we were already working with. And throughout some of last year, GPs embraced that, and we suddenly found that we were bypassing, or we were substituting care for about 6% of the acute general medicine patients that our category our patients fall under. And then as we opened that up to all healthcare providers this year, we are now substituting care for 10% of our general medicine cohort that is admitted under the Royal Hobart Hospital, just under 10%. And we're hoping to expand that as we expand. So where to from here? Well, we're in an expansion process at the moment. We should have about 30 beds by the beginning of next year. The aim would be there would be 18 acute and 12 gem. We're opening another clinical satellite in the community that will be able to provide care in our community health centre as well as patients' homes. And then we're hoping to evaluate that. Our aim over the next couple of years is to actually have about 50 inpatient beds and a satellite in the south of the city, as well as working for an acute palliative care ward, which our palliative care team is very interested in. And that probably leads us to questions about both our model and the Alfred's model. Thank you.
Fantastic. Thanks so much for the great presentation. So we only have one question, which will be for both the services. That is related to the directed admissions. And what is your process for medication reconciliation on admission? And do you have pharmacists to complete a home visit or telephone or telehealth consults to meet the standard 4 requirements? So we'll start with whichever service wants to answer first. Let's say Archana.
Sure, so thank you. We have a pharmacist on our service. So our GMAST team also have a pharmacist. So our patients would have a meds reconciliation in the emergency department, or they would have a meds reconciliation in the ward. But then we have a dedicated pharmacist also who redoes the meds reconciliation when the patient is at home. So we can ascertain actually what they're taking at home. And we look at aspects of care, like how are they actually administering their meds? Is it Webster Pack? Are they self-administering, providing additional education? And because we're delivering acute care, we do frequent medication changes. So the pharmacist is a key part of our service in terms of being able to do that safely and to provide the adequate education for patients to do that. It's certainly logistically a very challenging space, the medication administration for these patients.
And our nursing staff are also very competent at medication reconciliation as well, because the pharmacist is kind of a Monday to Friday role in large part, and there's a cover on the weekends. So nursing staff are also very competent in doing med reconciliation, and it's a really, really critical part of the work, because it's actually where we pick up the most errors and concerns in that translation from hospital to home. And it's something actually that we're talking about a lot at the moment around medication misadventure in this older, sort of more complex population. So it just forms a really, really critical part of the service as soon as they get home. And the other thing we do is when the patient is discharged home in the afternoon, our nurses will call them in the evening to make sure that they know what they're taking for that evening before we've had our first home visit, and often pick up potential risks there as well and nip those in the bud as well.
I can just see, sorry, if Liz and June have asked similar questions around how we manage that titration. So I might just quickly speak to that. It is very challenging. So it depends on the changes. We do sometimes supply, for example, oral diuretics as separate bottles for titration, depending on the cognition and capacity of the patient. We make sort of assessments on whether or not they're able to do that self-administration and titration, or whether they have a carer who can participate in that, or are they going to be a morning visit where we will administer the medications. We try and minimize the frequent changes to Webster packs wherever possible, but sometimes in the setting of acute kidney injury, etc., we may need to take medications out of the pack. So it is a very dynamic space. There certainly isn't a good solution that we have found as yet. It's something that we're looking at on a higher level within our hospital in terms of a unified strategy for medication management, because what we didn't mention is we also have a substantive HITH, which is about 45,
it's about
50 beds, yeah. And then we have a 45-bed better at home, which is our rehabilitation at home essentially model. So it's a common problem for all of them, but probably more so for us where we have the more frequent medication changes. I know the US models administer all of the medications and have them all individually packed. It's something that we have, we're aware of, but not something we've done yet. And we do have a locked box strategy, which is the other thing. We did have some patients with significant cognitive impairment where we might have medications like opiates or other sedatives and things that we don't necessarily want the patient to have access to deliver them. So that, in discussion with the patient and carers, we have at times employed having a box there that is not accessible to the patient, that we can then access when our nurses go to do the morning visits. And that's a bit of a workaround strategy that we've been doing as a PDSA. So hopefully that answers that question.
Thank you. And the Tasmanian team. So there were 3 questions. One in regards to pharmacy medication reconciliation. Then it was related to patients with Webster packs and how to manage them on a daily basis. Let's see what you've got.
Well, I might answer the reconciliation, and I'll hand over to the GM team about the Webster packs. The reconciliation, we have, I think we have 2.4 pharmacists. They work 7 days a week. And every patient that we see gets a reconciliation. Sometimes that has already happened in hospital with those inpatients, but they're actually a relatively small percentage of, I suppose, our total number of patients. So our pharmacists will work out what medications patients are on from a variety of sources. We will often go in and bring their medications out of their home to have a look at them, particularly if they're defunct. And then we try and simplify that, particularly for our older patients. And that's certainly where a lot of our, GEM model of care comes in. And I might pass over to Tess for.
Yeah, so I guess one of our core components on GEM at Home is reviewing polypharmacy and medication management, because quite a significant portion of our patients do have a cognitive impairment in the background. So we are able to pack Webster packs for our GEM at Home patients through our pharmacists and our pharmacy techs. It's very individualized depending on the patient. So we'll do monitoring of medication adherence. If we're noticing issues from packets and bottles, we can get our nursing staff to pack dosette boxes, and then we can monitor adherence or do nursing medication management depending on the patient's needs. And then if our patients are consenting, we can, if they haven't already had a Webster pack, set them up with a Webster pack, monitor adherence of that, and get our OTs in to do some functional cognitive assessment and management of Webster adherence. It is a challenging space. I guess we try not to make too many medication changes, but inevitably we do, even though they are more subacute patients. Often, because they are frail and multimorbid, they will have acute exacerbations while they're under GEM. We try and make changes depending on when their next Webster pack's due. So if we're wanting to, say, add a vitamin D or increase their mirabegron or something that isn't acutely needed, we'll wait until their next pack's due to try and minimise those changes. So it's just, I guess, working collaboratively with the pharmacist to come up with methods that make it easier for everyone. But it is a tricky space, and it's always evolving.
And we rely very heavily on our pharmacists. They are very much a key player in our team.
Perfect, thank you. The next one is a comment, but I'll make it into a question. How does your data support a substitution argument of hospital in the home? We'll start with the Tasmania team this time.
So, say that again.
So how does the data support a substitution argument of hospital in the home in your model of care?
Well, I suppose our data is showing that doing that full substitution of care is offloading our general medicine unit. And we still keep our very sort of low length of stay. And without our sort of rapid response arm, all of those patients would likely end up in the emergency department. And because of the fact that they're coming through being referred by another health professional, they would often have a high risk of a long length of stay in ED. So it's offloading those ED beds. Yeah, that's what our data is showing. It could be more robust, but that's where we're thinking we're having that impact.
Fantastic, thank you. And the Alfred team?
Yeah, I guess certainly our percentage of patients that we recruit from the community is far fewer, and we'd like to be at the level where the Tassie team are, to be honest. But I guess it's in the diagnoses and the coding of the data as well, and accurate coding in terms of the treatment that you're providing and the diagnosis that you're actually treating. And I guess from a sort of more operational perspective, we're looking at the percentage that we actually recruit and substitute from the ward. So what fraction of that in general medicine are we actually taking as well? And then looking at as well what we're saving in terms of bed days. So the chart that we showed you earlier, where it showed the percentage in Gen Med HITH, just shows bed days saved as well. So there's a range of arguments that we make, I guess, to validate that we're actually substituting inpatient care.
And from a pragmatic point of view, the way we see it is we look at intensity of care, and that's sort of the benefit of our ecosystem structure, is that if patients need an intensity of daily intervention, or daily review, daily nursing visit, then that is our hospital substituted model, and they will be in our HITH model for that reason. And if it's less frequent, and then they go into our complex care model, or they come back to our general medicine clinic. So we have those other avenues that we utilize to deliver care. And like Felice said, the majority of our referrals come ED referred to our general medical team saying that this patient needs admission, and then our general medical team make the assessment that actually what this patient needs is, can this care be delivered outside of the home via hospital in the home or via the community other streams, or does that patient require inpatient admission at our Sandringham site, or does our patient require admission to the Alfred site? So that's sort of how we're structured to ensure that we are providing hospital substitution care.
But we really are focusing on the coding, because we feel like we're actually doing our service a disservice by not actually highlighting the complexity. So there's quite a focused effort at the moment on how we're actually coding our work, and making sure that we're capturing accurately the complexity of care that's being provided from a DRG perspective.
Hopefully that answers the question.
Thank you. Next one is more, again, just about data and overall. So do you see an impact on ED admissions and overall hospital admissions and hospital DRG and length of stay? And we're going to add another question into that, which is, what are your average occupancy rates? So Tasmania?
Well, our average occupancy rates are around about 90%. Our length of stay is 5 to 6 days for our acute patients, and our length of stay for our gen patients is 12 days. So we do work on them quite intensely. We are probably, well, we're offloading our gen med colleagues by just under 10% of their workload on a daily basis. And the ED, they're probably seeing less of an impact because their numbers keep growing anyway, and we haven't got ahead of that. So they're not suddenly twiddling their thumbs, but they would be busier if we weren't here. By maybe 5 patients a day, which is, we're probably offloading the ED by 2 or 3% of their total presentations a day. It's just the patients we're seeing are relatively complex compared to the overall number of ED presentations.
Excellent, thank you. And the Alfred team?
We've had a number of model of care changes within our general medicine service within the time that we started HITH. So I think it's difficult to draw direct lines between our inpatient length of stay and the existence of HITH, though. So we have quite a small inpatient length of stay. Our average length of stay is 5 days. It's 6 days if you include the time that they would maybe be in the inpatient or ED setting. What were the other parts of the question?
Well, yeah, and just on the length of stay, it's a huge focus, right, in the hospital and everywhere, and it's in this whole question of efficiency. But some of the stuff that we've been trying to do is shift that mindset a little bit, because it's pointless being super productive and not effective. So, these patients that we look after do need an investment of time, and that's why we have the ecosystem, so we can move them into these more complex care models when needed. But that's really, really sort of critical for us, and to not sort of just be discharging patients for the sake of having a nice length of stay, because that doesn't end up in a good result for the patient or for the health system. We don't know the next part of the question. Would you mind reminding us?
So we do have the average occupancy rates.
Average occupancy sits at about 80%. It fluctuates up and down a little bit, but the turnover is like, it's quite reasonable. Like it's usually 3 in, 3 out on a day, on average.
For a bed state of 15. So 3 in, 3 out's quite a, and our medical staffing is a consultant and 2 advanced trainees. So to be doing 3 admissions, 3 discharges, and the care of those 15 patients plus the heart patients, which is about 110 to 120 patients. And our doctors are often mostly out on the road. So we do just revising, like the way we deliver care is outreach, or nursing outreach with doctors doing telehealth, or doctors doing telehealth, or reviewing patients in a clinic if they come to the hospital site for some other reason, an investigation and another appointment, etc.
Fantastic. The next one, we're going to combine again 2 questions, and it's more going to be in regards to engagement of the both medical teams inside the hospital as well as the GPs in the community. How do you actually what were your strategies to get them to come on board for this service? So Tasmania?
So our strategies there, when we first started, the original founding group of consultants for hospital in the home, one of them was the head of Gen Med, one of them was a geriatrician, and I was an emergency physician. So we kind of went back to our home units and did a lot of promotion there. We also had the rapid response service, which was GPs were already referring to. So with our new model of care, we essentially capitalized on our existing relationships with those services. Anecdotally, what our observation is, though, is that we've had a much easier time getting patients, probably from ED, but definitely from the community, because they need to pass those patients off to another service. And we've probably had slightly more resistance from inpatient units in the hospital because they're not necessarily as incentivized to hand those patients on to us. And that's always a continual, it's more effort to get inpatients in than community patients in. But basically, it's just been going out and chatting to teams. And then when we've opened up to our community nursing teams, we've capitalized on our relationships with the community nursing teams, that's because they're all government, that sit under the stream that we work in, which is subacute aged care and community. And then our ambulance service, we've capitalized on our links via the ED and the fact that our new offices are co-located with some of the ambulance service to develop those pathways. And then with our aged care facilities, some of our staff have worked in aged care and we have capitalized on those links.
Also, with our engagement in the primary health space with our GPs, we've done webinars with Primary Health Tasmania, which I think worked really well. And we also have a formal pathway page on the Tasmanian Health Pathways, which is a resource that our GPs use day in, day out. So they're two of the more formal things we've done with GP engagement.
We have done a lot. We had a very clear communication strategy right from in each step of the evolution of our services. So there was key stakeholders engaged, lots of consultation, lots of workshops, lots of education. When in the start of community rapid response, Naomi and I literally went to GPs with a platter of food in their lunch break and introduced ourselves personally and just really became present. But I'm sure with every HITH service, and this is definitely with all of the streams of our service, it was about building a rapport and accepting referrals, being a yes service, being solutions focused, and then coming up with, you know, other solutions if they didn't quite meet our box of inclusion criteria. And then having successful outcomes and then referring again. So it was really about just getting one clinician on board and then the next one, and then they'll keep on referring.
Fantastic. And Alfred?
So I guess we'll speak again to the more of the inpatient space, which is where more of our referrals come from. And I think we've highlighted some of that, the presence of a team within the emergency department, which has close links with our service, presence of the team at our daily journey boards where the board teams are going through all of the patients and we're able to contribute to those discussions, you know, identify any barriers or challenges to coming out to HITH, you know, this person needs a PICC line or, you know, what's their home situation? Will they be able to come really early on? And having that dialogue early has been really key in engaging board teams. I do think that one of the very key pieces, which I spoke to, is the rotational staffing of general medicine consultants and advanced trainees. We've got a home first approach across our department. And I think that sort of pragmatic approach is really important with this sort of care. I think it enables really valuable discussions around what are patients' values and where do patients want to receive their care and the risks and challenges around that. So I think it has been a lot about trust, and having ourselves embedded in that way has been a key part of that referral process. With the primary care, we certainly haven't gone to that space of engaging primary care actively. That is on our next things to do after speaking to our Tassie colleagues at the conference. It's certainly something we love about your model and admire, and having the single point of access is something that we are aspiring to. We do have GPs that have had patients through the hospital and the home model, so they're involved with us in that way, and we always give them the direct contact number to contact us again if that situation occurs, but hasn't been a major part of our service tool as yet.
I mean, I think you're in a really fortunate position in Tassie too. I think, I don't know, metropolitan GPs might operate a little bit differently. I think as well, it's kind of in ours kind of business model for a lot of them, and it's locums after hours. And I think it's great to have that buy-in, and we're a little bit envious of how well you've done in that space and at taking your lead and really wanting to expand on that. We have recently had the Priority Primary Care Clinic co-locate with our emergency department, so that provides a real opportunity for us to sort of leverage that. But I think we've got a lot to learn from you guys in Tassie in terms of reaching into GPs and creating those relationships.
Thank you. And now I reckon the final question we're going to have is, what advice would you give to other health services looking to replicate your success? So we're going to start with Alfred first and finish with Tasmania.
All right.
I think, that's a big question, Iftar. I think as Tassie identified, being a yes service, I think is really, really important, and being a patient-centered service and having a open mind to how the service needs to evolve to meet the needs of the patients that are referred is really important. We already had a fairly large suite of home-based services at the Alfred, but I think the key difference for us was the sort of attitudes towards delivering care and how we might support other teams to deliver that care at home, and overcome some of the barriers that physical and imaginary barriers that might exist to delivering that care, I think has been one of the key successes.
Yeah, I think it's about agree, and I think it's about begin with a mindset. We did lots of small experiments, PDSAs as well, to sort of test ideas before we upscaled them. We really surrounded ourselves with a network of flexible services to create this ecosystem, and working with people with like minds. We borrowed ideas shamelessly. We spruik our ideas. We wear badges saying home first. We wear red shoes to say there's no place like home. We talk about it all the time. And I started the workforce here with a biscuit jar theory. So I bought in biscuits every day, and we work in an open plan office with a whole lot of other services. And people would come and have a biscuit, and it would start a conversation. And it wasn't about necessarily talking about the business of the work. It was about creating relationships, and that really worked with our complex care program, the sharing the food and sharing the biscuits, because now 30% of our work is shared across those services. And I'm not blaming the biscuits entirely, but I think they might have had something to do with it.
Thank you. And Tasmania team?
I think there's a couple of ingredients. I think one, whoever's funding you needs to be sort of on board, at least with the general idea. You then need a core group of really passionate clinicians who see the benefits of treating people at home and want to move away from the paradigm that hospital is safe, because we all know that it isn't. And if you've got that really core group, then you can move forward and identify what the needs are in your area, because we've all evolved to fill needs in our own areas, which is why we're all so incredibly different. And then once you've identified those needs, we spent quite a bit of time going and visiting other HITH services. Some of you will have been on the receiving ends of our visits, to see what they do and how that might relate to the patients that we want to see. And we just had a really big appetite for risk. And I think that in some ways has come from our sort of multi-specialist team. We all have different strengths in that team, and some people are really comfortable with having people at home and taking risks, and some people are a bit more detailed focused, or able to discharge people focused. We certainly have clinicians are happy to take them home and then aren't so comfortable with discharging them. So our team coming together has really balanced out both the advantages of having different specialists and also some of the disadvantages that their innate training brings. And we're just happy to try things. Definitely, you have to say yes. You have to just keep saying yes and accept that some of those patients are going to fail, and that is not a failure. That is just a consequence of their disease process. We don't say it's a failure when a code blue or a MET call is called on a patient that deteriorates on the ward. And if our patients need to go back to ED, that's no different to a MET call. It's going to happen. And if it isn't happening, you're not treating sick enough patients. Yeah, so the rest of the team want to join in? Anything else?
Oh, no, I think just reiterate, it was really one of the key things was having that dedicated leadership team, and from a interdisciplinary scope. So we have, consultants, geriatrician, nurse practitioners, allied health leads, pharmacy leads, all on our leadership team. So we're making joint decisions.
And I think that one of the things that we have done, people keep complaining we keep poaching their staff, and I keep pointing out, well, make your department a better place to work and they won't leave. So we have really emphasized that if you come and work with us, we will enable you to work in a way that you want to work and use the skill set that you've developed. I mean, one of our nurses famously said to me at the end of their first week, and he's an ED nurse, he says, I've been resourced to do my job, I've been allowed to do my job, and no one's called me all week. So he hasn't been sworn at, he's actually been appreciated. I won't swear on, national podcast, but there we go. So yeah, our staff are really happy and we have quite low turnover, and that's probably the biggest key to our success.
Thank you. And I see that Darshana has their hand, or Felice.
Can I make a final parting comment? I absolutely agree with you, Sna, about the staff experience. I think hospital at home, these models have the potential to be much better than hospital care, both for patients and for clinicians. But I think it's really important for us to remember and to have the dialogue with others that this is not new. Delivering care in the home is not a new thing. Australia has been doing this for decades. Our hospital has had 30 years, just celebrated 30 years of hospital in the home. We are simply building on that legacy and taking that into a sort of new time of more acute care, more flexible care, more remote care, etc. But it's not new work, that what we're doing, and it's work that patients enjoy to be at home. So I think it's very exciting.
Thank you very much. Excellent. Thanks so much, the Alfred team, Tasmania team. As I said beforehand, if you're enjoying these webinars, please become a member of the HITH Society to continue supporting us, and we'll see you in the next one. Thank you, everyone.